everyone. Really nice to see you all. I know it's been quite a long day, and I know this is kind of the last panel of the day, so I'm really grateful. I'm really pleased to see so many faces still out there in the audience and online as well. Thank you for joining us at home. This is a topic that's very close to my heart. If anyone knows me personally or professionally, I'm someone who loves talking about challenge and life and all the challenges that life throws up and how we can get through those challenges that life brings and what we can learn from other people, what kind of support we can get from other people to actually help us get through those. So when National Academy said to me, do you want to host a panel? What do you want to talk about? I was like, let's talk about challenging times and how social prescribing can help us go some way in tackling some of those obstacles, some of those challenges, and create some ideas. And more importantly, actually think about some solutions. So again, I'm a challenge-based person, but I don't like a challenge without some potential hope of a solution. So at the end of this panel, and because it's the last one of the day, we're going to be talking about solutions, ideas about how we can overcome some of these challenges and support other people to do that as well through social prescribing. But I'm absolutely delighted to have a brilliant panel with me today. We are hopefully still going to be joined by Professor Kevin Fenton. He's been caught in traffic, so he may well enter from side stage. But we've also got some incredible people with me here today. So I'm going to introduce them. I'm going to introduce Nicola Gitsham. So Nicola is the head of social prescribing at NHS England and NHS Improvement. I've also got Christiana Melam, who's the chief executive of the National Association of Link Workers. And I've got Shiv Sharma, who is one of our participants in our, you got a bit of love out there, Shiv. Shiv is actually going to be one of our participants in our public facing campaign, which is coming out later this year. We're really excited about that. And Shiv has his own journey actually that he's been through, which I'm sure he's going to share with us. But thank you so much for all being here today. So please give them a round of applause before we start. So just to say thank you for getting involved in the big conversation. As you saw, James, our live scribe, was inundated with post-it notes. I don't think he's ever seen so many. So thank you for all of your thoughts and reflections. He's actually outside now and he's watching this panel, hopefully, and is going to be adding some thoughts and reflections as we go through this panel, but also some solutions at the end. So hopefully that visual representation will be a really nice record of some of the thoughts from today. But to start off with, I'm going to take some of those challenges, some of those issues that you all brought up during the big conversation, and I'm going to start really asking my panelists for their thoughts, their reflections, and potentially their ideas about how we can overcome some of these difficult things that we all face, or we're all supporting people who are facing. So Nick, I'm going to start with you, if that's all right. So I took a bit of a picture of the visual that James was drawing, and some of the things that were brought up there included digital literacy, us not really understanding or voicing the needs of children and young people, transport and infrastructure issues, funding access, lots and lots of things. I'd love just to get your take, first of all, about inequality, what your experience is of that in terms of your work and role, and how you can see social prescribing going some way to tackling that.
Yeah, thank you, Radha. So for the last year, I've been working with the Health Inequalities team at NHS England, and that's been fantastic learning. And I think what's really hit home is for the NHS, you have to look at what is in the NHS gift, so healthcare and social prescribing. Wow, you know, the holistic support and how it can connect people to community support is just needed, I would say, not just in primary care, but across the whole system. But then you've got those wider determinants and why we need to work really closely with all those partners across local authority, VCSE, local communities, and that actually we need to be very strategic when we're thinking about social prescribing and get that leadership really within these new integrated care systems, right at the top, at the board, but also at the place, which is often around the local authority, and in the neighbourhood. So I think you have to be quite strategic about it. So it's like acting really locally and with individuals and communities, but really making sure that it's connected up to that bigger strategy to address health inequalities, because that's what the Constitution says. That's what the new legal duties on ICF say, and also it's one of the 4 things that integrated care systems have. So we have something as social prescribing that's really tangible and practical to bring to the table to support people to make that change. So being really strategic. as
Yeah.
well as working really locally. I think that's important.
Yes, like you said, there are lots of different levels, aren't there? They all have to kind of align and be working together in order for outcomes to be achieved and for things to move forward. Christiana, I would love to get your take. Obviously, you as a person, but also in terms of link workers, what they're facing, what your feedback you're getting from in terms of inequality, how they're tackling that, what they're experiencing, and some of the worries they may have as well around, difficulties in their role.
Okay, so I think the first thing to say is that social prescribing is not an optional addition. So I think if you look at the primary healthcare definition, so if you look at the WHO definition of what primary healthcare is, you can see it is what social prescribing is about. It's about integrated care. It's about the wider determinants. It's about empowering people to take control of their health and well-being. So yes, we've got a national policy that has enabled us to be able to do that and enabled primary care to do that. But let's not think, is what's the role of social prescribing. Social prescribing is primary care. So what's been happening is that we've not had an effective primary health care system in this country and also globally. And that's the reason why you're seeing the health inequalities. So nobody has really been doing the proper preventative work, and we've been medicalizing people. So I think this is about demedicalization of healthcare, and we need to make sure that we are bold enough to define what we're doing and that the social prescribing link workers are supported. So yes, the social prescribing link workers role is quite complex. So that is about complexity. And if we look at it from that lens, then you can see that it has impact on the systems, then it has impact on an individual level and community level. And it also has impact in interprofessional and intersectoral. So everyone here who is doing community work or community groups or your VCSE, it has impact in that. So it's about driving that cultural shift in what we're supposed to be doing. So we need to acknowledge and kind of like reflect what have we been doing. So we've not been doing what we're supposed to be doing, which is what has resulted in this. And then of course, you've then got the social prescribing link workers caught in the middle of all this mess of how we've let people down or we've been medicalizing them. And then they're caught in within that space where people thinking their role is just about individual. No, they are the catalysts of change, that it's trying to uncover the social injustices that have been done to people. Primary healthcare is supposed to be about equity, inclusion, social justice. We've not been doing that. So you can just see the social prescribing link worker caught in the middle without that support infrastructure around them, not feeling powerful enough to be able to drive the change. So everyone in this room who has emailed their MP about social prescribing. So it's not just about us on this panel. We do have a collective responsibility to take action. It's not about just feeling defeated. You are paying taxes. We are in a mess right now where we've got obesity crisis, we've got mental health crisis, we've got health inequality crisis. So it's about everyone taking action. Email your MP, email your integrated care system. They are public accountable organizations. They are funded by taxpayers' money. They do have a responsibility and accountability for us. So as a social prescribing community and everyone here, we should be bold enough to challenge the system. Yes, it's about politics. So you better start emailing your mails, email your MPs and challenge them. What are they doing about social prescribing? What are they doing about link workers? Not moving around with begging bowl. I know people are going to talk about funding. You need to be able to defend what you're doing and make that argument to say what we've been doing. We haven't been preventing people from getting seriously ill. We have been medicalizing people. With social fabric, we've got a crisis. We've got COVID that has made communities to be disenfranchised. And then what we're now doing is that saying all this workload and all this is going on. So we need to be bold enough as a community, not attending conferences like this to seek for funding or what are we going to do, or just listening to us in this panel. So I'm challenging you today. What are you actually doing? What action are you taking to be able to challenge the systems who are supposed to be accountable to the citizens as well?
Mm-hmm. Yeah. Yeah, like you say, I mean, once you identify challenges and once we see them and once they're overt and right in our faces, we have to do something about them, don't we? And that means action. So action in all kinds of different ways and in all kinds of different levels. So thank you for that. Shiv, I want to bring you in because your journey, your lived experience of how arts and theatre supported you through your journey is incredible. And we're really grateful to you for being part of our campaign that's coming out later in the next few months. Would you mind just telling us a little bit about your journey and how you found yourself kind of getting into theatre and how it helped you?
Yeah, sure, Radha. Thanks for inviting me. Firstly, yeah, I mean, I'll be quite candid about this without going into too much detail, but I've got my own kind of life experience and lived journey of overcoming issues with addiction, and also coexisting kind of mental health issues as well. And it's quite poignant in the sense what Christiana's said today, because I do feel, although I've had so much brilliant help over the years, or had lots of brilliant help over the years, but addressing, say, for example, addiction and mental health solely through like a clinical perspective or through medication wasn't the answer for me anyway. And it was only kind of when I was introduced to like a very holistic approach that I found that my life was able to change. So, when I was, I mean, this is going back 10 years ago, but I was, I'm sure social prescribing existed, but it wasn't, it wasn't on my radar. But I was fortunate in the sense of I had other people, for example, social workers and occupational therapists, and a great other, team of people that supported me. And addressing the issues with the addiction was one aspect, but it was like taking that whole person approach and treating me as a person and looking at all the factors that were affecting me is where I got the most support. So here, I'm here today in the capacity, obviously, but primarily as a participant and also a facilitator now with Outside Edge Theatre Company, which is the leading theatre company in the country that works with people who've had addiction issues. They were introduced to me in a hospital close to 10 years ago when I was undergoing, medically assisted detox from substances. And I'd never been to a theatre before or kind of been interested in anything, been interested in acting or not knew that I was. And through like a community group like that, it was a really big part of my recovery journey. I discovered, a love of theatre, acting, kind of creative arts. And I'm kind of involved with lots of other good projects over the years, with Arts and Health London, who are here today as well. But yeah, so that was one aspect for me. So I feel that the whole idea behind social prescribing is absolutely valid and important. I mean, as I say, there was other people there. There weren't link workers as named, but I work for an NHS trust now as well. So fortunately, I've kind of moved forward in my life, and through volunteering and being signposted to Outside Edge and learning and community groups, I kind of got that support. And now, I've worked alongside link workers in like primary care network, GP, MDTs, and like I'm always astounded at the amount of local knowledge they've got. And I think that is the key. I mean, it's great that we're having strategies and stuff like that, but like the people that work in the communities, they know what's available. And like you've all said, there's so many societal, social, economic factors that affect people, as you said, a cost of living crisis, we've had COVID, all these things, but this is the important time where I feel that as communities we have to come together, and it's taking this society-wide approach, an asset-based approach towards people. People aren't problems to be fixed. They have the innate ability in them to change. We have to have that belief in them, unconditional positive regard, whatever you want to call it. But yeah, I think I don't know if that answers your question. Then
it absolutely does, and many more as well. So thank you so much, Shiv, and shout out to Outside Edge, who, like I say, is an incredible charity, and thanks to Natalie for your support in terms of the panel as well, in terms of supporting people who are recovering from addiction. So thank you so much, Shiv. I'm delighted to introduce Kevin Fenton, Professor Kevin Fenton. Thank you so much for coming. I hope the traffic behaved in the end. So Professor Kevin Fenton is a senior public health expert and infectious disease epidemiologist. He's worked in a variety of public health executive leadership roles internationally and in the UK. We're delighted to have you here. I know you're very busy. And I'm also going to say at the start that you have another event to go to at 4 o'clock. So if you need to slip off at the end, please do. It's not because he's bored of my questions. So Kevin, we've been, just before this panel, we were doing something called the Big Conversation, where we were asking people's views, reflections, experience of inequality, and their thoughts around how social prescribing could be one way to help reduce that inequality. I'd love to get your take on that and your thoughts and reflections.
Good. All right. Thank you. And colleagues, good afternoon. I'm so pleased to be here, and do take my lateness as a sign of my commitment to being here this afternoon because I'm so passionate about social prescribing and I'm so passionate about the work that you're all doing. I'm the Public Health Director for London, and I'm based with the Department of Health and Social Care and NHS London, and I'm also the Mayor's Statutory Health Advisor as well. So I have a unique opportunity both to understand health in the city, but also to work with politicians and leaders across the system to advocate for a much more holistic and inclusive approach to health and well-being. So you will always hear me speak about those wider determinants of health. You'll hear me speak about the whole person, and you'll hear me speak about inequalities as well. So social prescribing and inequalities go hand in hand for 3 reasons. Number 1, you have a unique opportunity to link to and to build upon community assets. And those community assets are fundamental for helping members of the public and communities to be more resilient, to engage with services more effectively, and to have better outcomes. So the first thing that I think you do is to be that link in the community that helps to bind those communities better and ensure those assets are leveraged. The second thing that you do is to help those of us working in statutory sector organizations and clinical sectors to understand the real world issues facing communities and to bring them to the core of our planning and programs. So I develop prevention programs for the city. I work with the directors of public health to deliver prevention programs. We need your insights to help us to do a better job of commissioning services and to ensure that we're providing the wraparound services that we need. The third area where I think you guys do a phenomenal job and where inequalities come to the fore is that you're able to ensure that the partners that have an impact on the wider determinants of health are brought closer to the health and care system. So whether it's your work with the educational sector, whether it's your work with the finance sector and citizens advice, whether it's the work with other areas which are really fundamental for helping people to live much more rounded and healthier lives and addressing some of those wider determinants of health, you're able to link it, be that link. So on those 3 levels, I think your role in inequalities are important. And please, when you speak about the benefits that you're bringing to communities, lead with inequalities, right? Because we're coming out of the pandemic where inequalities have widened and more of our communities are falling behind. So when you speak confidently that you're part of the solution in helping us to address inequalities in the city. Yeah.
Amazing. Thank you so much. Really, really helpful. I just want to, I'm going to break in a little bit for Q&A. So if you've got any questions for panelists, any comments, we'd love to hear from you. So get thinking about those. If you're online, then please also, you can put those in the chat and we will also try to give some of those to the panelists. I've talked a bit about the challenges and about the obstacles and the difficulties, but I'd like to turn to each of the panelists now and get their thoughts, I suppose, around, I know this is a difficult question, but one potential solution in your mind that is key. Now, whether or not that's a themed-based solution or a practical solution, I'd love to just gather maybe thoughts from each of you around what those solutions are. And James, who's watching our live scribe, is going to be adding those hopefully to our visual drawing from the big conversation as well. And then I'm going to come to Q&A. So, Nick, should we start with you?
Sure. So I think, just listening to what everybody's saying sort of sets out the case, doesn't it? And I think the one thing I would say, I've just been reflecting on how far we've come on the journey of social prescribing. And I do think it's unstoppable. I think there's some challenges to make sure that there's not variation around the country of where we've got great support and leadership and social prescribing and where people have little, but we've come a very long way. But I think the one thing I would say, Radha, is focus. So Bola Olawabi, who I have been working with for the last year, she has a great phrase of focus, traction, impact. See, because there is so much we could do. There are so many challenges in society right now, and we need to make sure that social prescribing reaches people who need it the most. That's why we brought in the proactive social prescribing service specification, and it's really exciting when you hear people saying they've redesigned their social prescribing service to make sure that it really is focusing those communities, particularly in most deprived areas, from particular minority ethnic communities, in inclusion health groups, people that really need this the most. So I think absolutely focus and decide where you're going to focus, get the traction and demonstrate impact. So I think that's, definitely important. And the only way we can really do that is know your data. I mean, I don't know whether you look at your services and see who are you reaching, and does that reflect the local population? And recognizing that data, I mean, public health is great, but we know it's imperfect. So listen to those communities and the co-production work. I mean, Sam was here earlier talking about green social prescribing, and just looking at that video that they've done in Bristol and South Gloucestershire and Northeast Somerset, really looking at how they've co-produced those green social prescribing offers with different communities to get some fantastic opportunities and more effective, more popular mental health offers than what's traditionally. They've had much better engagement in terms of their offer and effectiveness.
Amazing focus. I love that. And that's very focused as well. It's a focused answer, which James can, I'm sure, put in his beautiful picture as well. I'm just going to turn to Kevin first, 'cause I'm aware of the time. So Kevin, can I come to you in terms of I know it's a difficult question, but if there had to be one word, one sort of theme of solution to some of these challenges, what would yours be for today anyway?
So mine is going to be, I love focus, so I'll remember you stole that one from me, is about coordination. Because what you're doing is developing a part of a much richer tapestry of community-centered approaches to improving health and well-being. So social prescribers, along with voluntary sector organizations, in London, we have community champions. I'm not sure if there are any community champions here. We developed during the pandemic, outreach workers. There's a whole infrastructure of community assets. And so what I'm keen to see is, with the maturity of the social prescribing program, linking with those community assets to have a much more coordinated community offer to communities, I think is happening. I agree with you about removing the variation, building on best and promising practices, but we need to ensure we're linking more and the assets in the community are leveraged more. So I'd love to see coordination.
Coordination, focus and coordination. Can we make a word out of this? I don't know. Let's see. Shiv, I'm going to come to you next, if that's okay. From your experience, obviously, with your journey and obviously your role now supporting other people, what's that kind of one solution or one thing you think that maybe we're missing, we're not doing enough of, or could potentially help us?
I'll probably use the word focus here, but I'll focus and zone in on like the area that I'm kind of representing today. But like I would say, and I'm sure, sorry, I'm probably preaching to the converted here, but like a lot of them, you will already be doing this, but I will really say about kind of accessing, ensuring that you're aware of local arts organizations and those community groups, which might not necessarily be remembered all the time when we're focusing on trying to solve things like supporting people with debts or employment and, you know, all the other sort of thing. But yeah, I mean, I will just say being aware of like what's going on in your community. There's lots of untapped creative potential in communities. And I just would say, yeah, like, I'm going to steal a quote here if I can, but
Please do. We like quotes.
so this is from an acting teacher called Stella Adler, and I'm sure some of you will have heard this, but she said that life beats down and crushes the soul, but art reminds you that you have one. And I think that's, yeah, for me, that's something I would encourage.
That's beautiful. I love that. Thank you so much. Yeah. So localness, community, localness. That's a word. We've made that word up. That's okay. Christiana, what would yours be?
It's difficult to have one.
I know. I ask very hard questions.
So for me, I think the key thing there is demedicalization. I mean, it has to be said, we are drugging people. I mean, do I have to scream? We are drugging people. And I think that there might be a bit of malpractice that's going on where, you know, some greedy people they don't want people to feel better. I don't know. So I do think that we need to acknowledge, yes, bit controversial. It has to be said. There are people that are going to lose out. If people are living well, if we all lose weight and things like that. So I think we need to demedicalize healthcare, because healthcare is very medical. And we do know that 80% is not medical, is non-medical. It's not medical, it's actually non-medical. And I do have a problem. I'm going to poke Kevin a bit. So I think
Are you ready for this, Kevin? I'm next to you. Don't worry.
I think that public health is a bit downstream. So sometimes it's focusing on lifestyle. And I do think that this is where the social prescribing helps public health as well as helping our health colleagues, because it's upstream. And sometimes what you find is that people that are well off take advantage of some of those lifestyle interventions. And then it is the upstream and getting down to the social and wider determinants, preventing people from accessing that. So I think that there's a thing here about the way we actually see in public health's role, the way we're seeing prevention, and stop treating that as a commodity as well, and start understanding the context as well. And I also think that is something about how we see health inequalities as a deficit model. So yes, you can start from a deficit model, but he's just described how his assets was activated. So let's stop feeling sorry for communities. The other day, I was at a health center and they just put a poster that just highlighted all the health inequalities that were in the borough. And they were saying, you're going to die in 51 years, lots of prostitutes here, homeless people here, excess debt, no GPs, less care with compassion. And I'll just be like, what is that? So if it was a prostitute that walked in there, you stereotyped them by default to silence. And this is what I'm saying about highlighting these things. We are increasing social injustices that we are supposed to be calling out and empowering communities to take control. So it has to be asset-based. So whatever it is that you're doing, how are you activating the assets? How are you enabling people to be able to take control on the community? So for me, it's also about that power shifting. And we need to recognize some people don't want to shift the power. So it's about us dropping our ego and shifting that 100% to people and communities.
Thank you, Simon.
Can I respond to the poll?
So I was just about to say, Kevin, you have the right response. Or I was going to say, would you like to respond to that poke? I'm not sure.
Absolutely. I have to respond to the poll only to say how much I agree with you.
There you go. There you go. I knew that.
And, let it never be said that public health is only about the individual. I think sometimes the way it's framed by policymakers, it goes towards a sort of individualistic approach. But trust me, as public health professionals, we are always pushing back and saying, public health is more than the individualistic approach. It's about families, it's about communities, it's about society, it's about those structural interventions. So I agree entirely with what you said.
There you go. We've got a panel in agreement. How amazing. Now, Kevin, if you need to go, please go whenever you need to. Otherwise, thank you. Otherwise, we're going to now open up for questions and answers. So we've got a nice, got about 13 minutes. We've got hands up over here. So we're just going to get the microphone to you. So if you can hold your question until we get the microphone to you. Hopefully there's a microphone somewhere. Yes, there is. Thank you. Yes, please. Thank you.
Hi again, Aaron, the dancing pharmacist. A more simpler question. So in terms of granularity, I think the best way forward for everyone, for the world social prescribing community, nationally and internationally, will be potentially increasing the repository of SNOMED code, literally, because I've been talking directly with the top person. For 7 years, I've been trying to bash my head as a community pharmacist, not getting anywhere. Been working as a PCN pharmacist for the past 3 months. Sent an email to the CEO of SNOMED International. He invited me to the annual conference and he invited me to help create a SNOMED code for health. So I just said to myself, okay, so when I do a database search for SNOMED, there's a lot of condition, consultancy, therapeutic area. But when I was social prescribing, there's only 6 SNOMED code out of the 10,000. I'm like, okay, so if I was able to influence the CEO to kind of create one for Dance for Health, SNOMED code, then we could have every single one of you in this room creating your own SNOMED code for your specialty. Poetry, social prescribing, music, social prescribing, painting, social prescribing. So we are basically the foundation to the UK repository for SNOMED code, which is then compatible for all the countries across the world, because SNOMED International is a 30-year-old organization, and anything that's done in UK is compatible for every country. So.
Okay, thank you. Yes, I think you raise a wider point there, I suppose, about social prescribing being recognised and being kind of formalised, just like medical conditions are in terms of coding and records and data, for example. So giving social prescribing that validation and that standing alongside all the other things that we validate already. I don't know if anyone else wants to comment on that, or we want to move on to another question.
Well, Radha, just to say that there is a new information standard for social prescribing, and this is some of the things that we've been trying to look at. I wish I could Genie up, Jules, who's been working on this at the moment, but certainly it's something I'll take back for conversation.
Well, that's great. There you go. Fantastic. We like this. Bit of action, a bit of feedback. Any other? We've got got quite a lot of questions. Shall we go? I'm just trying to find. Shall we go into the middle there? Just thank you. And again, if you're online, if you've got any questions, please write them in the chats and we can try to.
This is a question for Shiv. Hi, Shiv.
Hi, Matt.
Hi. I'm just curious if you could talk a little bit about how your lived experience of being someone who received a social prescription, although it wasn't called that at the time. What is it like now to be the person delivering the social prescription as a practitioner? So how has your practice and your interaction with people coming into the outside edge social prescriptions, how does that influence what you do now?
It's a great question.
Well, I think obviously your own kind of personal journey, and it affects your frame of reference or the way you sort of see things. So I very much, you know, obviously my work with Outside Edge, but also my work with, in my other role with the NHS Trust, again, I work as part of a team of sort of multidisciplinary professionals. So everyone sees everything from their point of view, don't they? So, you know, you have MDTs and they're very clinical, but I've been very fortunate in the sense of having been exposed to different approaches. So I've worked in kind of employment support, I've done volunteering and supporting people into peer mentoring, you know, taking participants on trips to the theatre. We came here yesterday, just down the road to the Old Vic, and we saw Sylvia, which was lovely. But yeah, it's very much, you know, using the same thing. It's like a whole person approach. You know, we say person-centered care. How often is it person-centered when we're looking at it from just our discipline? You know, it's going to be natural. If I'm a plumber or something, I want to fix everything with a hammer. They say, I think there's something analogy like that. But yeah, I think it's just, yeah, to answer your question, Matt, I think I've been fortunate because I've, you know, having worked in quite a different array of health and social care settings and sort of approaches, I feel like, yeah, taking that, you know, looking at the person as the person and looking at, like, you know, we've already said what resources are around them, empowering them, because they're the experts on their own lives and we're just there to help them uncover that. So yeah.
Amazing, thank you. Beautiful answer. I think we've got time for one more question, so we'll go to the lady at the back in the black jumper. Thank you.
Hi all. So I think one thing we all do really well in prescribing is offer personalized care and really focus on that, what matters to me. I'd love to kind of hear from the panel about how we then marry that with standardization for evidence-based delivery of programs. Obviously, I kind of think that if something is personalized, surely we're having variability, and if it's community-based, it's going to vary on the community we're seeing in each different area. Then how do we kind of square that circle with kind of an evidence-based approach for standardization as well? That makes sense.
Yeah, it's a really good question. Yeah, how do you collate all that data with very personal stories and personal contexts? And yeah, anyone like to take that?
I'm happy to.
Do you want to take that? But yes, you go first.
So, such an excellent question.
It is.
Because it's personalized doesn't mean that it's not going to be evidence informed. Right? And we need to ensure that in our narratives, we don't say that because something is personalized, there's no evidence to support what you're doing. That's a very dangerous territory to be in. What you're doing, whether it's defining a treatment or a program in response to a problem, you're doing that based on what you know works. You're linking people to effective programs. You're linking people to culturally competent services. That is evidence informed. So please don't think that because it's personalized mean you're losing your evidence. And what I think is key is as you work together as a community to share your evidence informed practices. So there's more consistency. I think a colleague mentioned there's too much variation. So referral to citizens advice, referrals to music therapy, referrals to art therapy, that's all evidence informed. So let's keep that narrative together. I think it's really important.
Thank you. And I think just to plug, because I think Marie Polly will probably grab me by the neck if not when I come out. But just there
We don't want that. We don't want
there's
that.
some good mass resources on evidence. And I think, you know, that is really critical. I think it's coming from a position of confidence, Kevin. This isn't soft. There is good evidence that this works and why it works and why it, and how it helps the NHS say with, I mean, I'm from the NHS, the challenges they've got, know it, use it, be confident with it.
Yes, and we've also got a whole episode on evidence for social prescribing with our podcast subscription. So have a listen to that as well as a little plug of the podcast. Christiana, yeah, we've got just a couple of minutes. Yeah.
I think we should not reduce social prescribing just down to personalized care, personalization, because what I said is that this is about primary health care. So if again, WHO, all the nations signed up to what primary health care is about. We've not been able to do that. That's about integration. That's about enabling people to take control. And that is where the personalization comes in. And that's about integrated care. So social prescribing is more than just personalization. It is a complex, it's about complexity. So it has impact on the systems, community and individual level. And if you look at the Medical Research Council guidance on evaluating complex interventions, it will tell you to be careful with the way you're interpreting evidence and taking into account all the contextual factors. So I think that the personalization there is about, you know, contextual factors. And just to do a little plug that there is, obviously we are in one extra year within the NHS long-term plan commitment for funding. So if you are a social prescribing service provider that employ link workers, you better make sure you employ as much link workers as possible, because once that funding goes, the only those that are in post will be the recurrent funding will be guaranteed. So it's very important that you understand there is an urgency now to employ as much social prescribing link workers as possible, because the contract is going to go into the core GP funding.
Thank you, Christiana. Thank you. Thank you. So thank you all so much. So I just want to summarize. So what we've talked about, the challenges, there are lots of challenges out there. Life is challenging at the moment. But we've identified a few solutions: focus, connectedness, demedicalization, and local community. I'm glad I remembered all of those. I just want to do a little bit of a shout out before the end of the panel, just to say thank you to our panelists. Please give them a round of applause. Thank you for your time. And also I'd like to do a big thank you, because this is the end of the panel sessions. It's not the end of the day, but the end of the panel sessions. And just say thank you to everybody who is working really hard in the world of social prescribing, whatever role that might be in, whether you're championing it, whether you've lived it and you're now supporting other people with it, whether you're in policy, strategy, delivering it to local community, wherever you are, I'd like to say thank you. And can we give everyone a big round of applause for the progress that we've made so far? Thank you very much. Thank you, everybody. Thank you.